So good afternoon, everyone. Welcome to e-workshop series on COVID-19 by Public Health Foundation of India. If you have any questions related to the session, there is a Q&A section down below. You can put up all of your questions down the Q&A section. And if you have any issues regarding the audio and video of the webinar, please put it up in the chat box. Our IT support is there to help you on that. Now, I would like to hand it over to Director of Training Department of Public Health Foundation of India, Dr. Sandeep Balla. Over to you, sir. Thank you.
Thank you, Vishnu. Very good afternoon to all the colleagues, those who have joined from the different parts of the globe today. We at Public Health Foundation of India, in collaboration with RIS Research Information System, as well as Global Development Center, have started this series of e-web series for COVID-19. As world battles with the huge crisis of COVID-19 pandemic, which has put the healthcare system of various countries out of gear, we at PHFI, which is a public health tank set up by the Ministry of Health and Family Welfare, initially by them, we thought, why not we should continue our educational activities and appraise our healthcare professional to deal this battle. And we created this webinar series. It's a webinar series of 4 webinars in collaboration with Research Information System, which is another think tank based organization based at Autonomous Policy Research Institute that specialization in issues related to international economic development, trade, investment, and technology. They have their Global Development Center also to institutionalize the knowledge on development initiatives and promote their replication as a part of knowledge sharing in Asia and Africa with the help of their institutional partners, including civil society organizations. WHO has declared the outbreak of COVID-19 as a public health emergency of international concern. As per the recent WHO data, they are saying that 1.8 million confirmed cases all across the globe for COVID-19 has happened, and around more than 117,000 morbidities have already happened in 209 countries. In African region, there are around 10,787 confirmed cases, followed by 501 deaths. Southeast Asia accounts for 18,663 cases with 829 confirmed mortality till now. Healthcare professionals are the leading fight against the COVID-19, and to support that, PHFI in collaboration with RIS and GDC launched this series of 4 webinars on COVID-19 so that we should appraise them and they should act as a frontline workers to help this battle and to fight this battle. These webinars will provide the credible information on the pandemic and an opportunity to interest and better understanding for the science and the public health impact of COVID-19. Through this webinar series, we have tried our level best to appraise you on the magnitude, epidemiology, clinical diagnosis, and management of COVID-19 cases. Other than that, how to manage their COVID-19 with comorbid conditions, and what are the facilities for isolation, quarantine, and infection prevention. Today, to start the series, we are so great to have our eminent, our leadership from both the organization. I have Professor K. Srinath Reddy, who is the President of Public Health Foundation of India. Professor Reddy earlier was the head of the Department of Cardiology at All India Institute of Medical Sciences, and under his leadership, PHFI has established 5 Indian Institute of Public Health in different regions of India to advance the multidisciplinary public health education, training, technologies, and implementation support for strengthening the health systems. He was appointed as the first Bernard Law Visiting Professor of Cardiovascular Health at Harvard School of Public Health, and presently serves as Adjunct Professor of Epidemiology at Harvard. He is also the Padma Vibhushan awardee, and Professor Reddy is a member of the Government of Technical Task Force of COVID-19. He is also an advisor to the governments of Odisha, Andhra Pradesh on public health. We also have Ambassador Amar Sinha, who is representing the Research Information System. Ambassador Amar Sinha is currently the chairman of Interim Advisory Council of Global Development Center at RIS. He retired from the Indian Foreign Services as the Secretary of Economic Relations in the Ministry of External Affairs, New Delhi in June 2017 after a diplomatic career spanning around 35 years. He has served in different capacities in Indian missions around the world, including the Algeria, Buenos Aires, as well as Jakarta, Washington, DC, and Brussels. He joined the RIS as a distinguished fellow in November 2017 and has lent support to several think tanks focused on Afghanistan and other strategic issues. He also advises chambers of commerce on trade and investment issues. Before we start this webinar series, I just want to appraise all the panelists as well as the participants, those who are joined from the different parts of our globe today, that this is the first type of efforts of PHFI in collaboration with GDC and RIS. And today we are so happy to say that around 22 countries representations are there in this webinar, with more than 250 colleagues from different parts of the country, different parts of the globe. We are really thankful to Ministry of Health, Government of Rwanda. They have given their concurrence, and their health officials have also joined today in this webinar series. This webinar series is going to be a 1 hour series on every day on the same timings, because we thought this is the time which matches with the all countries timings. And followed by a question answer session, we have eminent faculty, those who are going to cover the different topics, and we are going to give you ample of opportunity to raise your doubts, and PHFI will be there at the back end support to give you all the replies in collaboration with the eminent faculty. Over to Professor Reddy first. Over to you, sir.
Good day. I do not know which time zones you are in. Therefore, let me say good day to all of you. It is excellent that we have this kind of an international collaboration of knowledge sharing, where we need a global trust to counter a global threat. COVID-19 has now become a worldwide pandemic, affecting virtually every country in the world. Some countries are still at the beginning of the pandemic. Other countries have fully experienced the ravages of that and are just beginning to recover. Others are now in the throes of the epidemic at its peak. India is now working hard to contain the epidemic through a series of measures that were taken from February onwards, with limitations on travel, with closure of schools and colleges, with limitations also on working in offices, increased social distancing measures. But since the end of March, we have now been in complete lockdown, with an extension recently, but with some relaxation in areas which are not very badly affected and which appear to be safe for certain types of activities to be taken up. Nevertheless, it is the science behind the understanding of the epidemic that is going to drive the solutions. And it's important for us to share this global learnings, not only in terms of the specific microbiology and the molecular genetics of this particular RNA virus, but also in terms of epidemiology, as well as the clinical presentations and the clinical management strategies, but also the entire health system issues of what is necessary and possible to do at the primary healthcare level, what is it possible to do at the hospital level, how do we triage the patients for home isolation, for hospitalization, and how do we actually treat the patients when there is no specific treatment yet available in terms of effective supportive care. All of these are important elements which bring in public health and clinical medicine, no doubt, but the whole gamut of social sciences and implementation science into the whole mix of a multisectoral response. We also recognize that this is not merely a medical or a public health issue. It has an economic dimension, it has a social dimension. Workplaces have been closed or greatly limited. Schools and colleges have been closed, limiting education. So we do need to escape from the grip of this virus as soon as possible, but without cost to lives and well-being, or at least minimizing that loss. Therefore, the public health dimension and the medical dimension does take precedence at this point in time. It is important for us to share the knowledge, as I said. And while we do have global health actually marching on through a sense of shared vulnerability, it is the shared values of global solidarity and of commitment to protecting all human life on Earth that is going to be driving our collective response. And therefore, to share knowledge is a very important element. And in these days where conferences and workshops are not possible, we ought to use our distance communication methods and IT technology as much as possible to build the bridge for communication and the bonds of collective response to this epidemic. And I'm very happy that the Public Health Foundation of India and Research Information Systems have joined hands together. There'll be multiple questions that will come up, and they are always being asked, both by the policymakers and the administrators and the media and the common public, as to what are the tests available, what types of tests should be used and whom and when, and how much of testing is really necessary, what are the symptoms and signs, and how is diagnosis accurately established, how is risk assessed, what are the additional elements that increase the risk, is it only age or associated disease conditions, and how do you actually manage milder cases at home, and how do you manage severe cases in the hospital, how do you prevent person-to-person spread, and how do you ensure that a person has actually become immune after having become infected and safe to go out? How do you know a person who has already recovered is not infecting others because has the virus really left the body? And is there a social stigma? How do we overcome the social stigma? What is the nature of a collective community response with community participation? All of these become very important elements in that kind of a multi-sectoral response, which calls for multidisciplinary learnings to be integrated. This tiny particle of RNA is bringing the whole world together in a collective response. And one of the key elements of that is knowledge sharing. And particularly since we have to use science at its very best to defeat a pandemic at its very worst, we need to have this kind of a conclave through the distance education, through the internet. And I'm, again, very privileged that PHFI has the enlightened partnership of Research Information Systems to take this forward. And I'm also delighted that so many participants from different parts of the world are now joining in this in order to share knowledge and exchange experiences and to build that broad, solid front of global solidarity, which will build the best wall of defense that we can have against this virus. Thank you very much.
Thank you, sir, for giving your valuable inputs and giving the remarks at global solidarity. I think this is the need of an hour, and I would request now Ambassador Amar Sinha to give his opening remarks on behalf of RES and GDC, sir. Over to Ambassador Sinha, sir.
Thank you very much. Thank you, Professor Reddy, for raising some very, very pertinent questions. Of course, first of all, I want to thank PHFI and RIS and GDC for taking this initiative when we are really in the midst of a global pandemic and a human crisis. But it is absolutely essential, as Professor Reddy said, that this is the time which really underlines the need for cooperation. We can only tackle this pandemic effectively and collectively if we can pool our resources, our knowledge, experience, and work together to save human lives. The 2-3 other points I'd like to leave it to the experts to talk about. But 2 or 3 things have become very clear. That beyond the human lives that it has already cost and it's going to cost, we don't yet know how far and how long it will continue. But it will change the world in many ways. It'll take a huge toll on the economy, on social aspects, on psychological aspects, perhaps in many countries, even political aspects will change. But now that is something we will all have to grapple with. Second thing which has become very clear, that the richest of nations, unfortunately, in their policy making, had failed to give due importance to public health and medical attention. I think that cannot be hidden, and it has to be brought to the center. The third thing I would like to say, that this has also opened a certain moral debate, both for health professionals and otherwise. The policymakers are grappling with what do they save first, lives or livelihood? Similarly, medical professionals are faced that how do we, when they are faced with shortages of, say, respirators or essential items, who do they treat first? That's a huge moral dilemma facing the medical professionals themselves. Other thing is what has never been appreciated, I think, in policymakers is the great role of public health professionals. And that is, I think, the crux. If COVID will teach us something, is to teach us to look at the health issues differently. Because today, this pandemic has really redefining the definitions of national security and development. And here I must say that what I at least feel, that today the front line are the health professionals who are not only protecting nations, but actually are protecting the humanity. And this, it will be one lesson if we learn from COVID, that going forward, redefine how you define national security, put public health in the center, and then work. It's not enough to just protect nation states. It's very important to protect the nationals and the human lives. So with these words, of course, I must thank all the health professionals around the world who joined today. A deep sense of gratitude is owed to all of them. As I said, they are in the front line. And as policymakers, we can only say that we would try and change the focus of governments and put more focus on public health and health security in future. So thank you very much, and it's a great initiative. I congratulate PHFI.
Thank you, sir. Thank you for your valuable inputs. Thank you for highlighting that the public health should come in the center now. And it is not only the COVID-19 which has created the public health into the upfront, but I think public health has played a great role since inception in all these type of pandemics when these pandemics have started earlier also. So thank you for your valuable inputs. And now we are going ahead with the series of the this e-workshop series which we are going to start today. I would like to appraise all the healthcare professionals, those who have joined today from the different parts of the globe. This is a 4-webinar series, and every day, same time, 3 o'clock, we are Indian 3 o'clock time, we are going to start this series. It's a 1 hour, 15-minute series followed by the question answer session. We have divided into 4 major topics. First is magnitude of the problem, epidemiology, clinical features, and differential diagnosis of COVID-19. Tomorrow, we are going to have a diagnosis and management of 19 cases, and after that we're going to have a session on management of COVID-19 cases with comorbid conditions, and the last session would be on preparing the facilities for isolation, quarantine, and infection prevention. With no doubt that there are multiple things to be covered in the COVID-19 crisis, but whatever best we have found within this capsule, we tried our level best to capture majority of the things. Today's session, there is a certain protocols that all the respective participants, they have full right to ask ample number of questions. There is a question and answer chat box at the down. If you want to put it up, any question, put it up into that question and answer chat box. All the questions would be answered after the session by the respective faculty. And today, to start the session, we have very eminent faculty who is the leading person for COVID-19 from Government of Haryana himself. He is Dr. Varun Arora. He is the Associate Professor in Department of Community Medicine. He has worked in license and with Government of Haryana since 2012 and serving as a resource person in many training courses and workshops across, looking after the preparedness and management of coronavirus as Officer in Charge Control COVID-19 at PGIMS Rohtak. So that's why we have taken the eminent expert for this particular session, so that you should learn from the horse's mouth itself that how from the at the ground level, the COVID-19 cases, the management is happening, the preparedness for the quarantine services are happening, the preparedness for all the isolation services are happening. So over to Dr. Varun Arora. Dr. Varun.
Thank you, Dr. Balda. Good morning, good afternoon, and good evening to wherever time zone you are in, and namaskar from India side. And I'd like to thank again Dr. Bhalla, and thank you Dr. Reddy and Dr. Sinha for kind words. And I will build upon that. This is a unique opportunity when the whole world can come together and also be helping hand for each other. And this is the time where public health is the real need of the hour, and it should be given due importance, as Dr. Sinha has already said. Yes, that should be given the due importance. Without further delay, I'll just start with the presentation. I request all of you to please feel free to ask questions, and it will be answered in the end when the presentation will be over. Dr. Bhalla, the presentation is visible? Yeah.
Yes, sir.
It's visible, yeah.
So today the talk is about COVID-19 magnitude, epidemiology, clinical feature, and differential diagnosis. I would like to begin with the phrase that for COVID-19, we are having information in evolution. Every day we are finding new things which are coming. We started earlier that it has a droplet infection and the transmission can be just to maintain a distance of around 1 meter, 3 feet, that is more than enough. Now, various studies are showing that it can be 13 feet also. There are doubts about aerosol transmissions, fecal-oral transmissions. So it is information in evolutions, and the presentation and the data we are showing today may have less relevance tomorrow. But yes, every day is a new learning experience for all of us. So beginning, we have heard a lot about coronavirus. I will just cover it in brief that it is a positive sense single-stranded RNA virus with a high affinity for host cell ACE2 receptors. It belongs to family of coronaviridae, and coronaviridae family is affecting us for a very long time, more than the centuries. Currently, we are talking about this COVID-19 virus, and the genome is 27 to 34 kilobase, and the size is 120 nanometer, which is 0.12 micrometer. As already said, that this large family of viruses has crown-like spikes. Because of it, the name, this coronavirus, has been given. Four main subgroups of coronavirus, alpha, beta, gamma, and delta are there. Alpha and beta are usually present in the bats, and gamma and delta, these are present in birds, which are also warm-blooded flying vertebrates. And the human coronavirus, it was first identified in the mid-1960s, and it was found in chicken in 1920s. That shows that the chain was getting transmitted in the animal, but whenever there is a contact with the animal and the human, so there are chances of some mutation, some adaptation, and humans also become uh, host, and then it spreads through various mutation and adaptation. These alpha beta viruses, as you can see, are normally responsible for common cold, and rhinovirus is very common. These also have been found in 1960 when they first were identified. And after 1960, NL63 alpha coronavirus was found in 2004, and HKU was found in 2005. But our major concern are the last three: MERS, SARS, and 2019 novel coronavirus. So talking about the microscopic structures, membrane, envelope, nucleocapsid, and spikes. Spikes are the very much relevant point of the studies, and most of the studies are done onto this, that if we need a vaccine, we have to find some way so that these spikes, body can develop antibodies against these proteins, so that it does, by a spike protein, it attaches the cell wall and it gets engulfed by endocytosis in our body. So these are the structures. So how do they emerge? This is, there are various studies and various, I think, I would say, hypotheses. Some are saying that whether it is a lab created virus or is it a virus which has transmitted from animals to human. Various hypotheses, various theories, but we don't have any clear-cut answer right now. So if we just go by the history, the most recent common ancestor, MRC, of all coronavirus is estimated to have existed as old as 8000 BC. And when we are talking about these viruses, even this alpha beta coronaviruses are 2400 BC time when they seems to be existed and continuously transmitted in the animal chain. 70 to 80% of emerging and re-emerging infectious diseases are known to be zoonotic origin. And on this, it is a little bit small. You can see that animal disease reservoir, and for coronavirus, bats are considered very common. And after that, there are intermediate hosts, other animals infected by blood, saliva, urine, and feces of bats. And then there is a transmission to human when the virus jumps into human. And a single example which happened in China in the wet. population growth, climate change, urbanization, consumption of raw or semi-cooked meat, international travel and migration increases the risk of emergence and spread of respiratory pathogens. And when it enters into the human, then occurs the adaptation. And there, this adaptation leads, like in this novel coronavirus case, it was considered to be transmitted via any spread through feces or saliva or blood or urine, but now it is considered to have an airborne, or rather we say droplet borne kind of transmission. And this was proven in SARS also. SARS coronavirus, as we all know, was lethal, and SARS coronavirus in 2002 became a pandemic. Then came H1N1 influenza, which was not a coronavirus, but it was again through respiratory respiratory transmission. Then 2012 MERS, which was having a case fatality of around 40%, and the reservoir was camel. And then came novel coronavirus with a case fatality of 3 to 4%. In various countries, it may range up to 5 to 6% depending on the healthcare facilities. So you can see how it got transmitted. SARS coronavirus was transmitted from civet cats to human in 2002. That was also through the wet market, and then immediate action was taken, and for some time the wet markets were closed. Wet markets are active in China for the last 3-4 decades. And the problem is when there are exotic animals which are coming in contact with the human and the feces and the animal cycles gets human becomes accidental host. In MERS, which was very lethal, it was through dromedary camels, which were considered as a reservoir for this. And then the studies are still going on, and we say that till now we know that it has transmitted through seafood market, but exact picture we don't know. There are many hypotheses. One hypothesis is that from bat it actually transmitted to intermediate host Manis pentadactyla, also known as pangolins, which are ant eaters. These are actually very rare animals, so they have been blamed, but there has been a big question mark onto this, because there is a matching of only 90 to 92% of genome of pangolins with this coronavirus, novel coronavirus. Some have found in their studies that in bats, it is 96%, the same virus was having 96% of genome, which is similar. But till now, there is no concrete evidence that how this transmission cycle, this is only one of the hypotheses. Incidental host is human sapiens, and then from human to human, it is through droplet infections. So talking about today, as you can see, there are very few countries which are not, I would say, touched. And even when we are talking about the islands like Maldives and Mauritius, they are also having now the coronavirus scare because of this air transport, these rapid urbanizations. Even one case has a potential to spread it in 1 month to 400 people, around 406. So you can see that by this graph, that what is the current incidence and the prevalence. If you see, most of the African countries are coming in a very less zone. This zone shows that there are less number of cases, but we should take it with a pinch of salt, because it also depends on how much is the testing capability of that country. As you can see, in USA, in Italy, France, Germany, what has happened? They have a lot of number of testing done, and based on that, the probability of finding the cases is also very high. The number of cases done in many of the African countries and the Southeast Asian countries are very less. So just saying that the number is low without having robust data of the cases tested, susceptible cases, confirmed cases, we should take it with a pinch of salt. It may be that we are just seeing the ice of the tip bug in these countries, and there is a lot of cases which are still we are not able to find out through active cases finding. Now this graph shows the same thing, that confirmed COVID per million cases, the density of the cases or the prevalence you can say. And again, it is evident that this Southeast Asian region, African regions are not having that much cases. This we can take from the other way around, that if you see USA, the whole of the Europe, we see that they are going 2 to 3 weeks ahead of us. and we still have that much window to learn from their experiences what went wrong. Many of the countries have already banned their air travels, which was very good initiative. But did we do this air travel restriction? Was it too early? No, it was not too early. Could we have done it earlier? Yes, we could have done earlier. Are we going for the total lockdown? Are we doing that much restrictions on the people to maintain the social distancing? These are the answers which every country has to answer when you see what is the spread. And this is the same. If you see both graphs, the deaths are really in common with the number of cases they are having. It is proportionate with the case fatality of already said 3 to 4%. But there are few countries like Iran, which I would say has got a lot number of deaths. Also with the Italy and Europe, there have been various theories like of the latitude theories, the temperature, along with like the we are having malaria endemic region in Southeast Asia and Africa, which is one of the protective because we are using chloroquine and hydroxychloroquine. Other is genomic theory that the genes which are actually the mutation in genes is not that much in the circulation, which other countries like others are having. So there are various theories, but needless to say, even one case, I am repeating, one case warrants for rapid response teams, active containment, because you never know that what will happen from one case. And I'll just try to show it with one of the graph that what can happen if you don't take care of these cases. So this is the epidemic curve, and the public health specialist can understand by this graph as it is going up. Some people are saying whether we have touched the epidemic. I would say no. If you see this graph, this is USA American region. If you see the south one, this is the European region. Now talking about this, which is East Mediterranean region, along with that Southeast Asia, which is down below, and Western Pacific. So if you see our number of Southeast Asian, African countries, and Middle East companies, we are afraid that we are just 2-3 weeks behind the developed countries of America and Europe, and we cannot go into the complacency mode. We have to be proactive. We have to learn from their case studies that what went wrong, so that these are purple and these blues should not be on the rise. You can see, and now you can say whether there is a plateau. The strict answer, the plain answer is no. The cases are rising. The doubling time is varying from country to country. Like in India, before lockdown, it was 3 to 5 days. After lockdown, now it is 5 to 7 days. But what will happen when the lockdown will be over? And what are the restrictive measures? Are we restraining the people in lockdown to effective manner or not? Are we finding the active case? We're doing the active case finding. These are few of the answers which you need to give for your own country. Only then we can see whether your country is going to have a plateau graph or a rising graph. And the same applies for the death. You can see the deaths, daily new confirmed deaths, and many of the deaths which are not reported. There are countries which are not having a robust healthcare infrastructure and reporting system. So we are not very much sure about these confirmed deaths, but still, it is still rising. As already shared with by Dr. Bhalla, that we are having 1.8 million cases, more than 1 lakh of deaths. So we are really looking at one of the pandemic, and we should be really very much scared of. So these are the various trends. I'll just show you one picture, and I think this will help you understand this. If we are talking about various things like, and this is the scenario of the Southeast Asia region. If I'm talking about Southeast Asia region, I'll go case by case in particular. This is the WHO site. You can see the top 5 countries are India with 11,000 cases, Indonesia with 5,000 cases, Thailand, Bangladesh, and Sri Lanka. So these are the 5 countries, followed by Myanmar. But again, I would say it also depends on your population, your geographical area. But even one case, even in Bhutan, you need to be worried about it, that even one case after 2 weeks can lead to 400 or 500 cases. And you can see here Like in various countries, it is topping the chart is by USA, then Spain, Italy, Germany, France. When the most developed countries are not able, which have a very good, robust healthcare system, tackle this situation. So just understand the gravity of situation in countries like us, that what will happen when we just talk about our places. And this is one of the infographics which will make you understand. This is by our word in data. And I'll just like to showcase one or two graphs which will make you understand that what is the situation we are having. Okay, so this is basically daily confirmed COVID-19 cases. It started from China on January 21st. You can see it like how it started. Then South Korea, Italy, Iran, France, and you can see, except for China, South Korea, rest of the countries basically are having a trajectory which is on the rise, except for one or two islands. But you can see rest of the countries, they are having a rising trends, and now they are getting static. But many of the countries like African and India are in on the rising phase. So you can see that these cases are having going to have a lot of problem. Now this is a graph. If you see when the first case was detected, that what are the daily number of cases, and more than daily number of cases, you see what is the confirmed per million cases, what is the situation we are having in various countries right now. So as you can see, slowly and steadily, first it started from China, and then it started having a lot of cases from China, other places. You can see these yellow cases where the cases begin. And this is the current situation. So you can see we are just lagging 2-3 weeks behind these developed countries. So we need to be very, very, very careful. So coming to the presentation again. So these infographics are available. I will just cite this example. If you see most of the success story, and one of the success story is South Korea, which did a lot of testing, even asymptomatic, because this is one of the unique disease where even the patient who are asymptomatic can spread the disease. So one advice, takeaway message is kindly advise everybody to use mask. Even the person is not having any symptoms, mask can help the person reduce that infection by getting in touch with each other. And I'll show the other case of Ghana, where there was increase in the total number of tests. As the number of tests is increasing, you can see the increase in death is very low. And we can see that India, if we are just going to go with the scenario that you are having more number of deaths, more number of cases, that it is not the answer. The answer is lockdown, social distancing, plus active case finding. If you are not doing the active case finding, you are just looking at the tip of the iceberg. Talking about the numbers, you can see in European region, these 5 countries, Spain, Italy, Germany, France, United Kingdom, and you can see the number of confirmed cases and also the number of deaths. So these are the problems we are seeing in the European world. In Southeast Asian region, already been discussed, the Bangladesh, Sri Lanka, Myanmar, Maldives, these are the countries which we need to now take care of, including India, that these are the countries which are going to have an uprising chart. And that depends upon the testing capability of your country. If you are not doing enough tests, like in India, the test is not going that much number. We are doing 150 tests currently per 1 million population. So this is a very less number. So we are saying that the countries like USA, who are doing 4,500 tests per 1 million population, or even South Korea and Japan, who are ranging between 3,000 to 4,000 cases per 1 million. So I will just ask you, what is the testing capacity and testing prevalence in your countries? So if your testing capacity is less, your testing per day, daily testing is low. So looking at the number, you should take it with a pinch of salt. So talking about Iran, Pakistan, and Saudi Arabia, you can see the Iran has already been in community transmission, which is stage 4, and we don't know where it will end. Pakistan is just at the same level. Saudi Arabia, there are still a lot of number of cases, but the deaths number in Saudi Arabia is very, very high. Talking about USA, already been discussed, and Canada, And you can see here China, which earlier had a lot of number of cases. Some people are saying it is not reporting, but you see Korea and Japan, which are the success story, and you can follow their footsteps how to go about it. And talking about the African region, you can see it is being talked by South Africa, which is having around 200 cases, then Algeria, then Cameroon, then you can say Cote d'Ivoire, and then Ghana, which is 566 cases. When there were 500 cases in India, India went into the total lockdown. Even there are countries, I would say like Ghana, Nigeria, who are taking it very actively. But my question would be, is active lockdown has been enforced with a full force, or we are having laxity into that? Because if we don't do strictness in this, it will lead to an epidemic form. The same is for Nigeria, 343 with 20 deaths. I'll quote the example that many of the deaths which are not reported, they are very suspected or probable cases of coronavirus because of old age. They are not reported. So active case finding, surveillance, death reporting is the need of the hour in the developing countries. And you can see even the islands like Mauritius, which has viruses only through transmission from the travelers, it is also having 324 cases. And talking about Kenya, 208 cases. These are WHO data. The actual figure may be higher on this. And you can see these are cluster of cases. So what we understand by cluster of cases is, if it is a sporadic cases, that means we are seeing somebody who has come from outside. Cluster of cases is kind of a stage 3 when you see the hotspots and local transmission is going. I'll address this later on. And talking about Rwanda also, it is also having 127 cases, but how much testing is being done? This question needs to be answered. Now this slide, it is little bit less visible, but I'll just cite example in front of you. You see, in India, this blue color is the test per million, 129. You compare it with Russia, which is doing 7,469 tests per million. Now talking about the same, in Turkey, it is 3,277. And talking about the various developed countries, it is ranging in 4,000 to 5,000. And now talking about the Egypt, which is also having a lot of cases. So you see that we just now, if we see, it is 244, which is again very less. So this will be the same scenario. You see Ethiopia, it is 28. The data is not available. Indonesia, 65. Philippines, 44. So my advice after this would be, please increase your testing capabilities, and active case finding along with lockdown will be the answer. So most of the countries who are able to control know the real picture, and they are founding their hotspots and working actively to contain them. So what is the status of your country? As per WHO, stage 1 is imported cases, which have come through either flights or through the ship. Stage 2 is local transmission. These are those cases who have come in contact with patients who have a travel history, and now they are spreading locally. Most of our countries are right now in stage 2. But now there are hotspots or the clusters which are having community transmission. So like India is at the, I would say, entry of the stage 3, where it is going to be community transmission but not proven. We are right now, we are having clustering of the cases where community transmission is going on. Community transmission is when a patient not exposed to any infected person, or one who has traveled to any of the affected and testing positive. Large areas get affected when community transmission. And stage 4 epidemic, we have seen it in China, Wuhan, we have seen it in Germany, we have seen it in Italy, France, Iran, USA. So when it becomes epidemic, there is no end to it, and the system collapses and most of the elderly population dies. So this was the point I was talking about. How much strong measures have you taken? I'm citing the example that this is an Oxford study taken by Oxford COVID-19 government response tracker, and it has shown that how much strictly government did the lockdown or the social distancing, the stringency index. It was based on the various scoring, whether the schools were closed, where there is no travels, no trains, no buses, and also no businesses, local businesses, no markets were open. And you can see most of the countries like Italy and Spain are
also very, but they did it when it already was in stage 4. So my advice to the developing countries like Myanmar, like Ghana, like Sri Lanka, which are the developing countries, that try to enforce your lockdown with the stringency index of around 90 plus. These countries like Germany, UK, US did it very, very late. And that is why, and even then, it was not very serious. Local air flights and was going on. And even China, they are now reducing it when the cases are going down. But my advice that kindly show your country's profile on the stringency index on the Oxford. If it is there, that where are you landing right now? So whether your lockdown, whether your activities are working or not, it can be seen by the doubling time. Most of the countries you can see has a doubling time of 5 to 6 days. This is the data which I will show was before 31st March. But after March, India, which was having a doubling time of 15 days, now is having a doubling time of 3 to 5 days. And after the lockdown was strongly implemented, right now we are saying we are having a doubling time of 4 to 7 days. So what is this doubling time shows? It shows what is the growth of that epidemic in your country. So most of the this African doubling time is in now in 2 weeks, 1 to 2 weeks, which is good. But again, I would say, do you have strong number of data to support it, that you have that much number of tests which have been done? So this is about the magnitude of the problem, the relevance of testing. Now coming to the epidemiology part, we all know that it has an incubation of 14 days and the average is 5.2 days. Globally, 3.4 percentage is the case fatality rate of COVID-19. You compare it with case fatality rate of seasonal flu in USA and it is 1%. Few countries are saying now it is between 4 to 5% also the case fatality. COVID-19 has a less case fatality, but the infection rate is very, very high, which is known by reproductive knot, which we will address later. So severity of symptoms in 80%, it is just mild or asymptomatic, and WHO just in April 14, their report has said that now this 80% has been divided into two. 40% are having asymptomatic and 40% are having mild to moderate cases. 15% will be needing oxygen, which will be having severe infection, and 5% critical infection requiring ventilation or ICU. So our concern is this 20%. So various studies, it is known that more than 50% of your population will be infected. So considering a country with a population of around 10 million, and we say 50% of them will be infected, which is around 5 million. Out of that 5 million, 20% would be 1 million. And now talking about this, do you have ventilator support for this 1 million cases? The answer is no. So what can we do? Rather than seeing 7,000 cases a week, as a public health expert, I would like to see 1,000 cases per day. And this is known as flattening the curve. That our system is having around 1,000 beds or 1,000 ventilators. So we have to find the ways and means so that the transmission, and till now there is only one wonderful drug, that is social distancing. No other drug proven, but only drug that is proven is social distancing. The second that is proven is active case finding, quarantine, isolation. So these kind of words need to be taken seriously from a public health perspective. So we don't have even for this the support. Who is at risk population? It is the decreased immunity and blood reserves because of the elderly population, and the others which are having multiple comorbidities like diabetes, hypertension, kidney disease, COPDs. I'll just cite the example tomorrow, 2 days before of our place, where we saw one case which visited 4 hospital because of kidney failure, and actually it was corona positive. So the hospital people and healthcare workers, they need to be also at very careful that what kind of cases they are. And it was not showing any cases. It was just immunocompromised old patient with decreased immunity, and where he developed corona, we don't know. So you can see the case fatality by age is any person above 50 need to be worried, and above 60 need to be very, very, very taken care of. We as healthcare workers are the people who are not going to have any disease or any kind of symptoms. We are just be asymptomatic, but we can transfer this COVID-19 from our hospital to our home. So advisable for your family would be maintain a safe distance. The same applies for the children. Children, the mortality is very low. It is 0%, more or less, but they can transmit it from children to the elderly. So you have to take care of elderly. Route of transmission, aerosolized droplet that are expelled during coughing, sneezing. WHO says it travel up to less than 1 meter. Mostly studies by USA CDC says that and Singapore also, they say it can be 13 feet. And 13 feet, if you say, it is around 3 to 4 meters and more than that. So basically, one MIT study says it can have a 70 meter also, and 8 meter is the average. There are studies in progress right now. Try to maintain social distance as much as possible. The second is distance of around 2 meters should be there. The third, which is basically always wear mask, wash your hands, and there is possible, they say that the airborne transmission, because infected droplet nuclei can travel more than 1 meter. It can travel up to 7-8 meters. So that these are not droplets. These are now, I would say, very droplet nuclei, less than 0.5 micrometer. And there have been various queries about fecal-oral transmission. Around 30% of the people which have recovered from COVID-19, when the sample of feces was taken and it was shown that yes, 30% of them were there was GIT multiplication of the virus, and they were transmitting these viruses in their fecal feces also. So this graph shows that the travel, you can see it is the airborne. Now it is very well proven that it is having more than 1 meter. Less than 1 meter, when there are more bigger droplets, and we can say that it can through direct contact, hand to mouth, hand to eyes, and this is the way it can happen. And then it can be through fomite bone. You are sleeping in the bed which is already having these coronavirus in that place. So trust me, as a public health expert, you need to understand these dynamics. Any infectious diseases, whether it will create an outbreak or not, are not, which is an estimate of average number of people who catch the virus from single infected person, is very, very important. Researchers are saying that it is around 2.2, 2.3, that one person is infecting around 2.3 people. So 2 people are infecting 5 people. Okay. And common flu, it is 1.3. So it is not a constant number. It will depend in the context of your country. The context would be whether you are having overcrowding or not, whether you are strictly maintaining social distancing, or this, I would say, any curfew or any other thing that you are doing, any measures you are doing. It will also depend on other factors like what kind of genomic virulence is there. So it is not a constant number. It will have a geographic variation, 2.2 to 2.3. And it is going to be an outbreak, because if we want to halt it, the RO should be less than 1. That means a person should not infect more than one person. So currently we say if we don't do any of the protective measures, no public health measures are taken, one case can infect up to 4.6. Oh, sorry, 406, 406 people. And if public health measures are maintained effectively, one person after a month will infect only 2.5. So you see how much public health measures, this lockdown, this mask, this hand hygiene, active case finding have an impact. From 406, we can reduce the number to 2.5, 2.6 as are not after this public health measures. So still it is not that much, I would say, effective. You have to go beyond that. You have to find asymptomatic cases. Asymptomatic cases, talking about, already said that 80% would be either having asymptomatic, 40% around them out of 80%, and 40% will be having mild to moderate disease. These asymptomatic patients are contagious up to 2 days before they develop symptoms. And you can see the study in Wuhan in Iceland. I will quote the Iceland study. 50% of the 892 cases study has no symptom but still tested positive. That means asymptomatic patients were found 50% positive transmitting the disease. So there has been another study, and this was in China by Arli, which says for every confirmed case, there are likely to be another 5 to 10 people with undetected infection in the community. So if I say I have 1,000 cases, I think I'm not doing active lot of testing, then I can say there can be 5 to 6,000, 5 to 10,000 cases, which I'm not able to find out in my community. So talking about this aerosol transmission, as we already seen, it go through infected hand to mucosal area of eyes, nose, and oral cavity, and it can sustain for a very, very long time on cardboard, 24 to 72 hours, various studies says, on plastic, 72 hours, on stainless steel. Only copper says that 4 hours to 8 hours, the virus dies. So on metal, it survives less. On copper rest, it can sustain for 2 to 3 days. We have seen the mode of spread, discussed them, that it is mostly respiratory route, seafood to animals. Still the studies are going on. Healthcare workers, so you have to be very cautious. Health officials, they see that it is through fecal matter. There is a question mark. US has said that there has been one case where it's through fecal matter, spillover mutations. So this was about the epidemiology. What are the transmission dynamics, agent, host, environmental condition. Now talking about the clinical features. Common in 87.9% of cases, we see fever as the most common clinical symptoms. Followed by that, we see it is normally the dry cough, and the third we see fatigue, which is around in 1/3 cases. So cases with fever and dry cough with potential history of contact with any susceptible or probable or confirmed case need to be tested. What is unique into this, which is not seen in other of the flu cases, is the sore throat, which is normally seen in other, we are in bacterial infections, and sputum, which is also in 1/3. So if you say a normal seasonal flu and others, there is a lot of rhinitis, lot of sore throat, but even they don't have a shortness of breath, which is seen in more than 20% of cases. Diarrhea and vomiting is very less. So you can see the most common symptoms: fever, dry cough, and fatigue. And the others are sputum, headache, hemoptysis, diarrhea, dyspnea, lymphopenia, SARI, severe acute respiratory infection, kidney failures, and deaths. Now here we see the difference between coronavirus. How can you differentiate them on the differential diagnosis? Already you can see that fever, it is common in coronavirus, but it is not common in cold. But flu, which is seen in America and a lot of other places, it is also common. But most common is differential diagnosis is from cold, which is very common. Fatigue, sometimes common, but cough, it is very common and usually dry. In cold, it is not. So in cold, what you will see, you say running nose, sore throat, which are running nose is rare and sore throat is also not very much common. So on fever and fatigue and cough, you can differentiate a person whether he is having coronavirus or cold. It is very difficult to differentiate it from flu, but it is being said. It will be covered in the next webinar. What are the clinical symptoms and management? Normally, a person comes with a cough and fever. Suddenly, on the day 7 or 8, he developed breathlessness. And how it happens, nobody knows. So it happens, he comes to us, and then we come to know that he is having some symptoms which are very relevant to coronavirus. It does not happen in flu. In the second week, the flu is very less probable to develop pneumonia, but in coronavirus, there is a lot of alveolar injury. There are various factors which will be covered in the next webinar. I will not touch it. I'm just touching the epidemiology part. So you see any person coming with fever, dry cough, fatigue, myalgia, with no history, with no running nose or the sore throat, considered it as a potential case of coronavirus. Risk factors already been discussed. Age, one non-modifiable risk factors. The others which are modifiable are immunocompromised, diabetes, cardiovascular, hypertension. So these are the disease, and also they say obesity, which can have a less number of your cardiac reserves and lung reserves. So you have, if somebody is having very severe obesity, also need to be considered a risk factor. Now there has been latest questions about immunity to COVID-19. Based on what is known about other coronavirus, it is speculated that COVID-19 antibodies will remain in a patient system for 2 to 3 days. Now there is a catch. There has cases which have been previously positive in China and are again found to be positive. The degree of immunity could also differ from person to person depending on the strength of patient's antibody response. So it is not very much conclusive whether the concept of herd immunity by natural infection is there or not, which happens in chickenpox. Like a person who has developed chickenpox naturally is for lifelong becomes immune, and they act as for our herd immunity in other places. So this is a scenario that herd immunity concept can only be seen when we have developed a vaccine, and only can be seen then. Now, definition is very important. As per WHO, a suspect case is a patient with acute respiratory illness, fever with one symptom of cough, shortness of breath, plus history of travel to a residence or country area of territory in your local territory also, which are the hotspots, reporting local transmission of COVID-19 during the 14 days of prior of symptoms onset. After these two, there is another or a patient or healthcare worker with any acute respiratory illness. So any case of severe acute respiratory illness, with or without confirmed test should be considered for a COVID-19 treatment, or has been in contact with a confirmed or probable case. The suspect case again already means any patient with and no other etiology should be also considered a suspected case for COVID-19. Now, the probable case. Probable case is a suspected case in which the reporting has been inconclusive, or the person where testing cannot be performed for any reason. So there are some deaths which are probable cases which we are not able to identify because the test was not given, and now the active surveillance of deaths occurring in the area, the probable cause, need to be done in developing countries. Now, talking about the laboratory confirmed cases, as per gold standard is RT-PCR, which is reverse transcriptase polymerase chain reaction. Most of the people know about it. But there are new tests which are coming. One is antigen detecting rapid diagnostic test. But WHO in their statement paper on 8th April, I have shared the link, says that WHO does not currently recommend the use of antigen detecting rapid diagnostic test for patient care, although research into their performance and potential diagnostic utility is highly encouraged, because the sensitivity and specificity of antigen detecting rapid diagnostic test ranges between 70 to 80%, and also on which day you are going for these tests. And another promising is antibody detecting rapid diagnostic test, which has been approved in USA and China. But WHO does not recommend the use of antibody detecting rapid diagnostic test for patient care, but encourages the continuation of work to establish their usefulness in disease surveillance and epidemiological research. Supposedly, after an year, you want to know how many people were infected, you can go for RT-PCR, which will be negative, and you will see in your antibody rapid diagnostic test, which will tell how many cases in a sample size were positive, which you can't do right now. But antibody detection rapid diagnostic test has some limitation. The good part is the test report comes very early, but it only comes positive when you have already developed the symptoms, and after that, on the second or third day of the symptoms, normally the antibody detecting rapid diagnostic test comes positive, which clearly shows that by that time the person has already spread the infection. We need tests who can also identify the asymptomatic cases, and right now we are only having RT-PCR who can also identify the cases. So talking about the RT-PCR, the samples, two samples need to be taken, one nasopharyngeal and oropharyngeal swab, and sputum if covered, if a person is in ICU, bronchoalveolar lavage can be done, RT-PCR amplification, and there the important part, ensure appropriate infection control measures while collecting samples. Most of the healthcare workers are found to be positive who were involved in the testing, sample collection, and also in the treatment part. In Italy, it is being seen that the 11% of total cases were around healthcare workers who were involved one way or another in the these testing part, or these tracing, contact tracing part, or in the treatment part. So these are sample collection part. These healthcare workers which are right now very precious assets. So kindly equip them with the adequate of personal protective equipments. Updated definition of contact. A contact is a person involved in any of the following during the 2 days before and 40 days after face-to-face contact with a person within a gap of 1 meter for more than 15 minutes. So somebody who was in a flight, there's somebody who was sitting on a 6A and the person who was sitting on 16B. If they have not been in contact and the distance is more than 1 meter, so we can say the person is having low risk contact. But high risk contact, it would be the person who are sitting next to them in within 15 minutes and within 1 meter and span of more than 15 minutes. Direct physical contact, and third is direct care of the patient, and most of the healthcare workers will come into it if they are not using protective personal equipments and other situations. High risk contact, already those who are touching body fluids of the patient, those healthcare workers who are treating the patient without PPE. In India, many prestigious institutes have quarantined their doctors because they have operated the patients, treated the patient without PPE, and the person was having any heart problem or any kidney problem. Later he came positive, and at that time doctors were not using adequate PPE. So my advice would be, any patient coming to your hospital, try to use an algorithm, a risk scoring based on his earlier contact history, travel history, symptoms of cough, fever, myalgia. So these risk scoring will just put them according to that. And if you're going for the operation of any person surgery, it is better advisable to do the corona test so that personal protective equipment, they can be utilized in a person who is positive rather than in every case. Okay, so based on that, I would go ahead that touch and clean the linen like any sweeper or any bearer or any class 3 class 4 worker who are working involved in the cleaning part, household ladies, and lived in the same household, close proximity, more than 6 hours passenger in the same flight will be also high risk. So if the flight duration is less, 2 hours to 3 hours, we can consider it as a low risk. Okay. So a student going to the school and there is another student in another class. So they are not having high risk exposure. Okay. Same room, but the distance is more than 3 feet or 6 feet. So distance can be more. So traveled in the same environment in the different bogie, so there is not much of the risk, so low risk contact. So you can quantify the person based on the history, whether it is high risk contact or low risk contact. Whom to test, already been discussed. International travel, contact healthcare workers or hospitalized patient with severe acute respiratory infection or influenza like illness, or any asymptomatic direct or high risk contact on a confirmed case should be tested. Even the asymptomatic high risk contact should be tested between day 5 and 14. Now this is very important part. This one slide is the crux. Regular hand washing. Regular hand washing. I'm repeating it again. I will show a slide by WHO that what are the 5 rules of hand washing. Then second, cleaning and disinfection of surfaces frequently touched by hands. And in this, most important that comes is basically those people who are used in the cleaning part, and it should be done 2 to 3 hours in COVID hospitals or the places which are involved in the screening part. Then cough and sneezing hygiene. Most of the people cough like or sneeze like, and this is where the problems comes. If you are wearing a half sleeve shirt, you have to cough like and if you are wearing a full sleeve, use your elbow. But try not to use your hands. Just don't use your hands and then change your clothes. Cough etiquettes are very important because once a person is coughing or sneezing, he can spread it, and that is why it can spread up to 13 feet, so which is a very big number. Avoid shaking hands. Do namaste, do adab, but don't do shake hands. Use mask religiously. There are different masks for different healthcare workers. It is considered N95 masks are to be used in healthcare workers who are involved in the treatment, in screening, and also in COVID hospital in various other procedures. N95 mask is having 95% filtration rate for any micron or any particle who is more than 0.3 micrometer. In the first slide, I discussed the size would be around 0.12 micrometer. But It is not the virus which is spreading. These are the droplet nuclei, and the droplet nuclei, I already said, has a size of more than 0.5 micron. So you are safe using N95 because the pore size is smaller than the droplet nuclei. The important part is most of the infection has been seen when the mask is removed and it is worn again, removed, worn again. Avoid it. Once you have just used the mask, even the 3-layer mask has a bacterial and particle filtration efficiency of 92 to 95%, a 3-layer surgical mask. They can be used. It should be used for 2 hours, but once you have worn it, you should not remove it even for a cup of tea or water. So before wearing mask, before using PPE, kindly just do all the, I would say, drinking water or having food or going to the toilet. Once you have used mask, don't touch it, don't remove it. Otherwise, the effectiveness of N95 and other masks will be worn out. Again, the important as public health is surveillance of all influenza-like illness. Like in India, there are fewer clinics which are running in all the hospitals, government hospitals. Any case with a history of contact with symptoms like cough or fever is advised for a test. And then when the test is done, and he is advised for home isolation or quarantine. And keep diabetes and hypertension under control. Take care of your elderly. And this is important. As a healthcare professional, stepping up the hospital infection control practices. Doctors are at a very, very high risk of getting infected. And this is one of the vulnerable group of high contacts. So you have to use hospital infection control practices. So what healthcare workers need to do? The first thing, before entering a room with a suspected or confirmed COVID-19, gloves, gown, mask. After that, you also need to protect your eyes with goggles. These has to be done. And even if you have a cap available, you should also wear a cap. Okay. You have to check the seal check of N95 mask when you are just going near a patient. Okay. The other thing is, which is important, don't touch your eyes, nose and mouth with gloves or bare hands until proper hand hygiene has been performed. Okay. If you start coughing, sneezing or develop fever after you have provided care, if you are a healthcare worker involved in the treatment part and you develop any cough, kindly go for the test right then and try to quarantine yourself, self-quarantine yourself for 14 days, even if the report is coming negative, because you can come positive later. Now here comes the part of sensitivity and specificity. I'll go to a back slide. On the test, RT-PCR has a sensitivity and specificity of 100%. But there is a problem. When we are taking swab from nasopharynx, the probability of spreading of virus is 62 to 65% according to some studies. When we are talking about oropharynx, the probability of virus spreading is around 32 to 35%. When we club these two, the probability of virus in our swab is around 75 to 80%. So despite 100% sensitivity and specificity, sometimes our sample is not very adequate. You may connect it with the tuberculosis test when we take two samples, because in one there can be no tubercular bacilli spreading. The same can happen into this. So we advise it should be done on the day 5 and day 14 when the chances of having the replication of virus is very high. Second, the person who is expert in taking sample should take it. So even 100% sensitivity and specificity, you can miss some of the cases based on the sample taken, their transportation, cold chain maintenance. So many factors do play a role. And when we are talking about antigen and antibody, I've already said antibody testing on the second day of the symptoms have a sensitivity or specificity between 70 to 90%, but it is not 100%. Okay. So we have to be very much cautious about any healthcare worker who has developed cough and fever. These 5 moments of hand hygiene, it is very, very important as wearing the mask. First, before touching the patient, just sanitize your hand. Second, before engaging in clean or aseptic procedure, clean or wash your hands. Third, after body fluid exposure risk, wash your hands. After touching the patient, wash or sanitize your hand with a sanitizer alcohol rub. And 5, after touching patient surrounding. So these 5 hand hygiene that you are going to see a person, you need to sanitize your hands for 5 times. Now, very important, hospital preparedness. Those people who are involved in the hospital infection control or preparedness or making the development, sparing the beds, training, very, very important. Training for all doctors, nurses, paramedical and housekeeping, including in private sector, because knowledge is weapon. Again, repeated knowledge, how to wear mask, how to don, how to do the donning, how to do the doffing, because most of the healthcare workers are infected while wearing mask, while doffing the dress, while not using adequate PPE. These kind of, I would say, cases where we are getting a large number of healthcare workers infected. Second, as a planner, you need to have a stock of, have a stock of 3-layer mask based on your consumption, based on your total number of doctors available, health staff nurses available, your bearer sweepers available. Also, adequate number of disinfectant like surgical spirit. And right now most of the countries and WHO has already advised that there are WHO preparedness tool which you can see on the WHO site, that if you are a developing nation and what need to be prepared, they will give you an algorithm which you can fill for yourself. So WHO has given the document. I would say Africa has an edge over Southeast Asia over this. Last 2-3 years when there was Ebola virus, we see in that scenario there were Ebola readiness, and that will apply to the hospital preparedness to tackle COVID-19 also. The trained healthcare workers who know infection control, because the same principle were applicable on Ebola also. The second is a rapid response team is developed in most of the countries where Ebola was very much prevalent. So you just need to reactivate those rapid response team. Followed by that, you also had isolation unit and areas in your districts, in your states, in your province, and in your hospitals. So what we need, like Africa has one edge over the Southeast Asia because they already had that much trained manpower, these isolation unit and rapid response team. What you need is adequate stock of PPE and again a training and a little bit of modification. And again food arrangement for the passengers and the other contacts under observation. So if you are a hospital administrator, you need to develop a triage area. After you take the information in a triage area, prior to any waiting area, screen patient for COVID-19. Okay, this limits potential infection, and you can do it for every patient coming to your hospital. Just find a normal algorithm. After information like poster and flyer that reminds patient and visitor to practice good hygiene, there is an area. Prepare a well-defined and separate waiting area for suspected cases with a gap of around 1 meter. Every person who is coming for test or they used to, there it should be mandatory to wear the mask. If they are not wearing the mask, provide the mask. Be alert for anyone that may have symptoms like cold, and they should be given priority and they should be seen with adequate PPE. And always have alcohol-based hand rubs or soaps and water hand washing station readily available for healthcare workers. Protect your workforce. This is very, very important. You cannot generate your workforce within, it takes 4 to 5 years to develop, to prepare a doctor. So they are your key and you have very much cautious while using PPE. Now talking about public health measures, this is, we are coming to the end. Maintaining social distance. The social distance is keeping away from each other, wearing masks at least 1 meter or more than that. Active case finding, which are having a brilliant example of South Korea and China, Japan and then China. But South Korea and Japan did not let this disease ever. They started using mask on the day one. They did a very good quarantine. They even did the active case finding on the roads of the travelers. So they did a lot of testing, more than 3,000, 4,000 cases per million. So they did not let even an asymptomatic patient spread the disease. They caught them when they were just trying to spread the disease. Through case and outbreak investigation and contact tracing. Contact tracing is very, very important. A person who is coming positive today would have met around 200, 300, 400 people. And if you don't trace them, those 300-400 people would have contacted all others. So you have to be very, very cautious. Many case studies in India have been there where contact tracing is there. And you have to prevent, like you can be asymptomatic, so you have to wear a mask also. And so that you cannot spread it to your patient. It can be symbiotic relationship. Your patient is wearing mask, using hand hygiene. He is not able to spread any infection to you. You are using mask, you are using hand hygiene, and maybe you may be asymptomatic person, but you still you'll not be able to spread it to others, even sitting in your OPD areas. Stepping up the surveillance, severe acute respiratory illness, adequate information, education, communication for masses. There is lot of infodemics, wrong information. There are kind of social outbreaks, and there are kind of where police has to take law into hand. So people are taking law into hand, and police have to take strict measures. Try to develop a good mental health of the community through broadcasting positive messages, and also involving social distance champions, some of the people who should be trained to maintain understand the psyche of the people. So these are the few of the things I wanted to share. These slides will be shared with you, and these are the few links where you can go and get the whole picture. And I would say the role of every healthcare worker, every police person, every person involved in the sweeping, cleaning, all the even person involved in the administration, every person role counts. It is an epidemic. We have to fight. I will just end with one line. There was a big fire, and all the animals came out of that forest. There was a sparrow who used to go to the river and just put a little drop in his beak and try to dropped it into the fire. The fire did not end it. Every animal asked that sparrow, "Innocent sparrow, what are you doing? This will not end the fire." But the sparrow said, "I know that the fire will not end, but in history, when the name will be written, my name would be written as a corona fighter, and your name would be written as a corona spectator." So every healthcare worker is a corona fighter, corona warrior. So I wish you all the very best for your countries and all the very best for future. Corona namaskar. Shake hands. Thank you so much.
Thank you, Dr. Varun, for elaborating this topic and covering the various aspects of epidemiology, clinical features, and differential diagnosis, and the magnitude of this issue, which has created a pandemic all across the globe and affecting around more than 209 countries. If I have to summarize your talk, there are few things which you have highlighted it very clearly, and which clearly summarize your talk, that public health measures are playing a critical role for such type of pandemic. And in that public health measures, we have social distancing, we have quarantine, we have contact tracing, we have surveillance activities, because we should learn the lesson from Africa, which when the Ebola has evolved, and how the Africa has worked extensively to fight for that Ebola disease itself. And there the rapid response teams have played a great role, and these type of measures, public health measures, have a great role to do with fighting with such type of disease pattern. Another thing I think which even the Ministry of Health, Government of India is highlighting very clearly is social vaccine. Social vaccine is none other than, but it is social distancing and quarantine. I think this is the key word. This is the key thing which India has started the lockdown as per the lessons which we have learned from the other countries. And now why South Korea has become the shining star, because South Korea has applied these measures very strictly. They have put it up the mask to all the population. They have done the lockdown, they have done the contact tracing, they have done the active case finding, they have done the testing. And that's why South Korea, if you see the South Korea and the US, the first case when it happened in South Korea, and the first case when it happened in US, it is almost the same timings. But South Korea, because of the strict public health measures, they have achieved a plateau now, and the other US, you can see that condition is worsening day by day. So I think the public health measures have a key role to play to deal with such type of pandemics. So we need knowledge, no doubt about that, but action is more important. That is the another key thing, and that is the emblem of our Public Health Foundation of India, that knowledge to action. So knowledge is required, but if you don't act upon that knowledge, then everything is going into a vain. So we have to act accordingly also. Another thing is that I want to highlight is that there are so many myths which are going on. There are so many. I think we should be very careful regarding the IEC right messages. Because the public enter into different kind of rumors, different kind of myths. And once you are in a lockdown position, and today being an IT revolution which has happened, we are always on Google's, and we always search, and it's known as a Google doctor. So every person has become the Google doctor by searching every disease pattern before reaching to the doctor itself. So that person has much more knowledge as compared to the doctor, because he talks differential diagnosis, 10 differential diagnosis in front of the doctor itself. So I think the knowledge, whatever the knowledge we should have, it should be the correct knowledge, and that knowledge we should percolate to our community. No doubt, sir, that all our healthcare professionals, those who have joined today or those who have not joined also, and those who are a part of the different parts of the country and the globe, and those who are acting as frontline warriors for corona, they should act as a corona fighters. They should not act as a corona spectators. And we wish that all our healthcare professionals, those who have joined today in this webinar series, they will get the benefit from that webinar series. This is our humble attempt of Public Health Foundation of India in collaboration with RIS and Global Development Center to appraise our international healthcare professional regarding whatever the efforts the Indian government has taken it up, and whatever the learnings we have so far for managing this COVID pandemic. We should try to percolate the right messages to them and give them the knowledge innovations which India has created, if it can help it can help their states, if it can help their countries to learn from us, and if we have an opportunity, we should also learn from them. So it's a mutual learning platform, and we are really thankful that people should help us and give their thoughts also, what learnings they have into their countries regarding that. Regarding this pandemic situation fight, we also want to learn from them. I think there are number of questions are there. I would request you to answer that question on behalf of PHFI. If Ambassador Sinha, sir, are you there, sir? Are you there, sir? I think
No, I'm here.
Okay, so anything, sir, you want to say before they enter into question answer session, sir?
No, I'm just listening. It's to all the experts. Good.
Thank you, sir. Thank you. So over to Dr. Varun to answer the various queries.
Yeah, thank you. So as I can see, the first question that has come, the condition in India and Myanmar are quite similar. What preventive measures should we prepare not to spread COVID infection as a primary care physician? Sir, I would say we will have to take preventive measures at 3 levels. The first level is individual level, the second is community level, and the third is at the national level, the government level. As per my knowledge, if I am correct, that till now no lockdown has been enforced in Myanmar, and it has been said that there are only 74 positive cases in Myanmar, up to my knowledge, which is there. I may be wrong. This is the data which I can see. But again, I would say the number of tests which are done is not satisfactory in that situation. So I would say, as a primary care physician, the preventive measure first at your level would be protect yourself with adequate number of protective preventive equipments. And the first in that comes is social distancing, as already been discussed. The second is use of mask, hand sanitization, use of gloves. Along with that, repeated sanitization of the area, avoiding a direct contact. And there has been very creative things like elongation of stetho, use of a plastic film, and using an algorithm whether the person is having high risk or not. So these are the things as a primary care physician we need to follow, and in the community also need to advise that you should not be fearful of such symptoms. We have seen in some communities which are trying to hide when they are having developed the symptoms because of fear of quarantine, before of the I would say not welcoming response by the government. So you have to develop a element of trust between the community and the doctors and the government. And the third, which is very important, that the government the native government need to learn from the examples of other developed countries, of other low and middle income countries who are undergoing and are 1 or 2 weeks ahead of them. So I would believe that social distancing, lockdown, only essential services to be, I would say, activated. Lot of things which I think India model can also be studied into this. So this is the one of the answer I can say. The other is, according to some, COVID-19 mainly affect HB. Asif Farouk, mainly affect hemoglobin. That should only cause reduced SaO2 initially, but in COVID we have both reduced PaO2, SpO2. How do you explain this? I think, sir, this mechanism will be discussed in the next webinar. The only thing I would say, even till now, there have been studies how it is affecting our body. There are two different domains to this. One is when your body is in a hyperimmune response, developing antibodies against your own alveolar cells, and the second is where you are immunocompromised and the virus is getting an opportunity to replicate itself. But affecting HB and detaching it with this is one of the the things. A lot of studies are going into this. I think this will be answered in the next clinical management part. How would you differentiate when I said COVID from seasonal flu in primary care? I think I have discussed this, ma'am, in my presentation. Why the severity is different in all across the world? Because, ma'am, it depends, because it depends upon two things. How robust is your system? Is there any immune, I would say there is a genomic theory also. What is the immunity of the community, and whether there has been any mutation in the virus? Like they say, the virus in the Italy that is prevailing so many deaths had 3 crucial mutations, and the one in India is having 1 mutation. So there is a genomic theory also. There is also robustness of the healthcare system, like a person who is coming in the mild or moderate situation, and there are other many pharmaceutical and local immunity, so many other factors which are playing a role, but we don't have crux answers to this. Only concern is when the most developed countries are not able to be saved out of this pandemic, when it propagates to the exponential growth in countries like India and other middle income countries, do we have that much of reserve of healthcare workforce who can manage it? The answer is no. So only thing is prevention is the answer. So next question is, what can be done in country where the testing is very low, such as Nigeria? It's a very good question, sir. I would say in such situation, forced home quarantine, even there should be an algorithm, and every person who is coming for it, develop the capacity for the testing, the first point. The second is, even you don't have the capacity, advise and motivate your local people that anybody who is developing cough or any fever, he should self isolate and or there should be quarantine. It happened in Italy. They started developing self isolation at home when they developed symptoms, but that was not enough. When there was a team of China which went to Italy, they said that home isolation is not enough. You need to either quarantine or isolate these people, and that is why the hospitals were made. So I will advise you, start developing your these educational institutes, museums, to hospitals which are capable of taking care of COVID suspected patient. I'm repeating the word COVID suspected patient. A COVID suspected patient need not to go to hospital. He can be very well managed at another stopgap arrangement. It can be a museum with beds. It can be, but there should be they should be taken care of their mental health. So such kind of countries where you don't have that much of lab facilities or test facilities, self isolation, forced quarantine is the answer. Which criteria set for testing SARS-CoV in India? What do you know like to recommend criteria for testing of SARS-CoV in Myanmar? We have followed the WHO policy, the criteria of a suspected case. So these are the people, and suspected case definition of WHO I have already shared, which clearly suggests any person coming in close contact in the last 14 days with any positive case or a travel history, any healthcare workers involved in COVID-19 and developing disease. And there are other options also, a person traveling in the same flight or in the same train, and the person is, or any contact tracing, a high risk contact. So these are the persons who need to get tested, and the same can be applicable for Myanmar. Any case of suspected contact should be tested. And contact tracing is very, very important. You need to identify through his history of the last 14 days. So our WHO algorithm can be followed into the testing, and depending on your capacity, whether you are able to provide rapid blood tests, like in India, rapid blood tests has just entered, but its relevance into epidemiological study is very high. But still, RT-PCR capacity building is very much important because it can also detect asymptomatic patients. What's the benefit of doing, Asif Farouk has asked, what's the benefit of doing antibody test for healthcare workers? Sir, it has a lot of, I would say, epidemiological surveillance benefit, that if you have 100 healthcare workers who are involved into this, many of them, 80% would have developed mild flu, or and because of their work profile, they would not have the kind of went to the hospitals. So if the antibodies are coming, so this will be a learning lesson for all other hospitals, that how much is the infection prevalence in your healthcare workers. And this can be used as the people who were using PPE, the people who were the healthcare workers who were using PPE, adequate PPE, and the healthcare workers who were not using PPE. After 2-3 months, how many of them have antibody, and in which group? So it can be kind of an RCT also. It can be also a case control studies plus retrospective study. It can done. It can also advise the doctor if the antibody test is coming positive. The first thing to be done, forced isolate that person for 14 days. Followed by that, do the contact tracing of all other contacts, either the fellow healthcare workers. This will give us an opportunity to find other asymptomatic healthcare workers. So try to understand this. Even that he has developed the symptoms, but within this duration, he would have infected others. And if we quarantine those people, so I will just cite this example. It happened in Delhi when one of the one of the doctor who was a positive case, his family also became positive. So what government did, they did the contact tracing of all other doctors, all other patients that doctor met in a mohalla clinic. So what happened, we found those patients, we actively isolated them so that it does not burst into the community. So hope you understand, even a healthcare worker can burst it into the community, and those contact healthcare workers in the last 14 days of disinfected healthcare workers need to be quarantined. Otherwise, this will be a cascade chain. For example, a physician who is having contact with 3 other physicians. Okay, he comes antibody positive, and he just had dinner 3 days back with one of the 2 fellow physicians. So as one of the hospital superintendent, I will quarantine these 2 people. I will do their testing and also ask not only this person, these 2 person also, how many people have you been in contact with? For example, these 2 have been in contact with 5 other people. So this kind of 8 people we will be able to save in time because of this rapid testing and then doing the contact tracing. So it has a lot of role in contact tracing and also in the epidemiological study. Please, is there any information for exposure prophylaxis, especially for healthcare workers at high risk of contact? There are not much of the evidence into this. There have been few pharmaceutical drugs. One is hydroxychloroquine. The evidence is not very much robust. The other is ivermectin. But these are considered for all healthcare workers who are in high propensity, but not post-exposure, high propensity. I hope you understand that if there is a post-exposure, that means there is a protocol. The person who is asymptomatic, there are treatment guidelines for asymptomatic patient also. He can be treated like in India, there have been various protocols by AIMS, which says that hydroxychloroquine with SG, looking into the QT interval prolongation, it should not be there. There are other drugs which have some pre-exposure effect, chemoprophylaxis, which is hydroxychloroquine, ivermectin, generalized immunity enhancers, and like citrus foods and others. But till now, WHO has not recommended any treatment, any post-exposure prophylaxis, even pre-exposure prophylaxis. So every country, depending on the data available, is using these evidences to develop their own advisories and the strategies. Should all the fever cases be isolated, Rupak Bhandari? not all fever cases. First, it will depend on whether you are in a stage 2 or stage 3. What kind of scenario we are facing. If these are sporadic cases, not every fever case need to be isolated. But if you are in an area where there is a local transmission going on, then your strategy will change. There you will see every fever case as a suspected case, because it could have come in contact with any of the asymptomatic patient in the last 14 days. So it lot will depend on your local transmission, whether it is a hotspot, whether you are in stage 3 or this is a stage 2 but a clustered area. So based on that, the policy will change. Next question is, should countries not deploy measures practicable, realistic to their peculiarities in the prevention of infection transmission rather than the current widespread practice of adopting total lockdown? Yes, sir, and many countries have done it, but there is one very important issue I would like to say. Till now, the evidences which Japan, South Korea, and China has shown to the world is, one is active and forced quarantine of asymptomatic cases which are contacts. Second, social distancing, and the third is sir, Dr. Sinha, would you like to say something?
No,
No, no, sir. Please go ahead. Please go ahead.
please go ahead, sir.
So the third, you see, the lockdown. These are social. These are the basically evidences we right now have. We don't like, there have been various curative evidences in the form of plasma replacement and other strategies, other treatment. But I would say, as per your resources, as per the dynamics of the spread, as per the evidences available, so you have to use various criteria. Whether the you are using, like, lockdown is not advisable for all the countries where you have a lot of poor, lot of people who don't, but you have to weigh. This is known as risk benefit. The other we use is a shared informed decision. And the third one, which is very important in using this, is like the evidences in context in which area you are living. For example, you are living in an island and there is no case. There is no need of any lockdown. But you're living in a clustered area where there is a potential of spread. So the intervention need to be tailor-made, and an economist, public health specialist, the government, the politician, and also I would say the common society man should sit together to develop their strategy. What about compulsory use of face mask by all in addition to social distance? I think this is the need of the hour, but people should understand these face masks can be homemade also. You don't need a 3-layer surgical mask for everybody. Use any handkerchief, any other mask, and this has been shown as an evidence by Japan and South Korea, where use of mask was mandatory. And respiratory etiquettes, they have a lot of importance. The next questions, I think 3 questions by Dr. Rubak. Since RT-PCR is costly investigation, should we repeat the test in highly suspected? Various governments have different guidelines. In Government of India says, if RT-PCR is coming, you have to do on 5 days, between 14 days. And if even it is coming negative and the doctor is of very high suspicion that this is a case, or even a SARI case without COVID-19 positive, need to be treated as an RT-PCR. Yes, it should be repeated based on the depending on the test availability and the doctor's suspicion. Do we need to test for COVID-19 for patients with influenza-like illness and who do not have travel history or contact history? It depends on which stage your country is right now. Thank you, PHFI, and thank you. And how do you in India responding to the issue of poverty versus the need to reduce transmission? Very important question. Should we close public market? What should be the government's response to that? I would say, if you see the scenario of India, and after me, Dr. Sinha and others can add to it, we have already made a plan where every poor will be provided food ration for 3 months for free of cost to all the individuals living below the poverty line. Now, this is a very difficult task looking at the 130 crore people, but still it is being done. It is being followed religiously and daily reporting is being done. The next question you asked, should we close public markets? There have been partial lockdowns, complete lockdown. Various districts and the states have given their advisories, and there are timings like 7 a.m. to 10 a.m. that this market will be open, but the people who are coming, They have to maintain the social distancing. This has to be done under the preview of the law. So there have been some relaxations. It is not a total curfew. There have been relaxation into this, but yes, you need to understand your local dynamics. I would always say there are chances of less deaths from corona, from poverty, if you don't have that plan in place. So you have to take care. Again, I would use the word of risk benefit ratio, that which is more important, and whether you have the availability of available food and sustainability for those poor and reachability also. So any plan you made, it should be relevant, answerable, actionable, and timely to that area. So you have to filter it through these filter criteria. Thank you. Savaya said, how did the countries that did not go into lockdown decrease transmission? If you see, I would first start with the contrast. I will start with the example of USA, who didn't go into the lockdown immediately, and you can see the scenario there. The countries which did not go to the lockdown, they had 2-3 things which were very much clear. The first thing was active case finding, which South Korea did, Japan did, use of mask, cuff etiquettes. Followed by that, they had a very robust system, even the use of IT. Like if you see in China, not a single person could go out of their place without using the app, which shows whether this person was COVID-19 positive or not. So use of digital, so country government could see where are the clustering of cases who are going to the market, and if they are going to the market, they can be restrained. So there are many unique and innovative approaches which followed. But how many success story do we have? If you see, we have success story of South Korea, Japan, China, but there are other countries which are actually showcasing us that these are the ways where you can spill over the virus to a large community, like USA, like Italy, like France. So you have to be very careful. Thank you. Hidayat has said, would like to thank you for the good presentation. Thank you, sir. Would to know what consequence do not make massive testing, and by your thought, the world will stand for longer as long. What will this pandemic end by the scientific reading best? Uh, I think this answer, nobody has this answer. A lot will depend how various countries' government respond, how proactive they are. Along with that, what are the factors in that contextual, I would say, how long this air traffic will be stopped. Again, there are a lot of factors. As per few projections by the study by John Hopkins, they say that the effect will last up to 2021 end. And they say the partial lockdowns will keep on coming and going even in USA and other places. And then we will reach a state after 2020 when we will see a low transmission, like we are seeing of swine flu, when we are seeing a low transmission. But right now, there is projected that 50% plus population of all across the world will be infected within a span of 1 to 2 years. These are all projections. A lot of trajectory will change over depending on the government actions, community participations, and by God's grace, if the mutations are there. So a lot will depend. Is there is a symptoms analysis done in India? Yes, sir. There is an algorithm which is followed in various fever clinics, which based on their symptoms and history, do the weightage, give the number of 3, 6, 9, and accordingly they are screened in the fever clinic. What are the problems that your country have to face when lockdown start? The first is wrong information. The second is panic among the community that we faced. A lot of people wanted to go home and they couldn't because they were locked down at their places and they were afraid. So the mental health and the psyche of the community and the population is very, very much important. When there is a lockdown, they need to have faith that the government will feed them despite having no earning. They will be taken care of. So this was the first problem we faced. The second was reaching the last man, which we ensured that even the people in the community need to be provided food once in a time. Many people have come forward, donated, and also there has been unique initiative by local NGOs. So I will ask you, like in Europe and other, like in Africa and other places, develop that NGO system, social society, CSOs, and those will have a lot of effect on this when they will reach those communities. The other problem we faced was like the other healthcare problems, like non-communicable diseases. They have got a second setback. So many people are now not able to get the treatment for the stroke or for the heart attack or the diabetes because of lockdown, because of no other transport available. So problems have been many. But let's see, if the corona, like now we're at right now having 10,000 cases, if it would have been not lockdown, we, as per projection, would have seen in India 2 lakhs plus cases. So what would you like to see? 2 lakhs cases without lockdown or 10,000 cases with lockdown? So lot of factors will come into play into these. Your local government policies, your political will, public health expertise, and the future forecasting for 2-3 months is also very important. If you don't have food reserves for your people, kindly don't go for lockdown. You need to assess your preparedness when you are prepared in the form of your foods, grains, social security, also plus your testing ability, your hospitals are prepared. So you have to weigh. It is a very complex phenomenon. So that is the answer to this question. If the community, Dr. Puru, if the community has no COVID at all, will this be any good for the future as herd immunity will be nil? Dr. Puru, I would like to say, if the country has no COVID, first you have so many tests done to prove it. How many tests you say? And again, I would say there is doubt on the herd immunity concept. So even those who are getting infected are shedding viruses. They say that up to 14 days they don't shed viruses, but now it is being seen that even the positive cases can shed virus between 14 to 28 days. So now this is a dangerous situation, a cured patient. But these are very small studies, small evidences. I would only say right now on this part is that uh, more than herd immunity, if social distancing is done, it is practiced, followed by natural immunity enhancers like any local yoga or some drugs, some remedies. So they can improve the immunity status. If you can safeguard, you can do the cough etiquette. So these kind of things will help rather than thinking about the herd immunity. And please don't try to don't think of introducing any COVID positive with the thought process that it will develop any herd immunity. There are no scientific evidence regarding this. Uh, uh, PRO, thank you, sir. Thank you, doctor. Thank you, sir. My question is regard to hand washing. What kind of hand sanitizer would you recommend, and how much of amount of hand sanitizer to be used in one occasion of hand disinfection? It is a very good question. There has been a lot of studies regarding the hand sanitizer. They say any alcohol-based sanitizer with a strength of 70% or more, ethyl alcohol, we say, is a good hand sanitizer. It can be liquid based, it can be gel based. So it is also in the form of addition with 2-propanolol, and there are complex formulations. But 70% alcohol is the minimum advocated, with others chemicals and other fragrance that can be added. And along with that, there has been some studies which says that benzyl alkonium based disinfectors don't have that much effect as alcohol based sanitizer. So I will just have one word of caution if you are using only benzyl alkonium based sanitizers. The second question is how much of the hand sanitizer to be used in one occasion. It is considered like 2 times you press it if it is gel based, and if it is liquid, 1 time. You say if you have 10 ml of this, so it is more than enough. And you do, the process is very important. You first do it straight, then on the other side, then you do this like this, then you do the thumbs, then you do the nails, and then you do your wrist. The whole process take 20 seconds. So WHO has given their guidelines. So depending on the strength and the gel based, the concentration may vary. Since we have shortage of health staff, at our setup, Sonam has asked, here a team of doctor and nurses manage a positive case for 10 days and then goes into quarantine, when the new team of doctor and nurses goes into the another 10 days to take care of COVID cases. What do you suggest? Should we increase the frequency of rotation or increase the duration of care by a team of doctor? Sonam, I would advise that this is a very good strategy. It will depend upon how many teams. The advice is team A, team B, team C, and then by the time team C is there, team A should repeat. How many numbers and how many days of the doctors you can put in a team, it will depend on the availability of doctors. The thumb rule is kindly don't overexpose or unnecessarily expose your reserve healthcare workforce. So either take them at home or take them away from the hospital area so that they can be used in case the first team comes positive and even one person is coming positive. Regular testing of healthcare workers, those who are in the 10 days, need to be done if somebody is developing symptoms. So this is, I think, depend upon various countries. So, but Team ABC, this kind of principle, many places have followed. Right. Thank you, sir, for this. Okay. And Linda Bhati has asked, can someone who has recovered from COVID-19 still transmit the virus during the 2-3 years after recovery? There has actually, the oldest case we have right now is only 3 to 4 months old. As 31st December was the first days when China declared it, and after that WHO declared it as a pandemic on 11th January, and other nominated it. 30th January, sorry, as it. So what I would suggest is that there is very less evidence whether this virus will behave like HIV or not. Because even in HIV, when we say there is very less viral load, it can survive in your body. We are very much skeptical about it. Till now, we are saying those who are coming negative, the probability, but how much time the virus will survive, and can there be relapse? A lot of answers which need to be, a lot of questions which need to be answered. So more than 2-3 years, like virus. This is a classical example. You are saying like typhoid Mary, who was a carrier. So you just want to say that can people can be carrier? So most of the asymptomatic patients, when they can behave as a carrier and they don't have any problem, so we can see such scenarios. I would say a lot of epidemiological studies are going, and many of them are, especially in China, are taking repeated sample of those who have now recovered from the COVID-19 and looking into the scenario whether they are in any case can shed virus in their nasopharynx or the fecal oral transmission or through droplet methods. But still, I would say we don't have answer to this question. For your information, when we have lockdown taken place in Yangon and Mandalay, so very good. And I would say lockdown with active case testing, this is the need of the hour. I don't know much about what is actually right now going on, so I was just going through the net. So I don't know whether it is in whole country or it is in those hot spots where it has been done, but it's the need of the hour. Level of PPE for primary care doctors. So WHO has also given guidelines. I will only say into this, depending on the place you are working. If you are working in any area which is COVID where COVID suspected patients are there, it is in the treatment part, aerosol generation, or any testing which is involved in the COVID. There is an advice of complete PPE starting from head to toe, and there is Corona kit, HIV kit of that level. Like in HIV kit, when we use the whole cap, mask, there are various standards which are given, like the PPE level should be like the apron they are using, the plastic apron, the sheet they are covering. It should be the best quality, 180 GSM, minimum 90 GSM for HIV kits. So the standards have been laid down, and shoe cover, the whole they need to cover, and many of the videos are available. So for primary care doctors, and there are not much cases there, like there is nil cases, not reported cases. So I would advise repeated hand sanitization and a triple layer mask is more than enough if there are no cases and very less cases. As the cases appear, I will advise N95 mask with repeated hand sanitization, repeated sanitization of that area with sodium hypochlorite solution or Lysol solution, maintaining the social distancing, risk assessment of the patient. So with each level stage 1, stage 2, stage 3, we will improve our level of PPE. So it will depend on many contextual factors. But if you are in COVID-19, the full PPE from gloves, double mask, N95 plus mask, and a lot of 2 masks, earlier 1 mask, then 2 masks. So there are guidelines, but it depends in primary care physician with we don't know. What is the cost of testing using RT-PCR in US dollar across the world, Augustine? Sorry, sir, I don't know the answer to RT-PCR testing in US dollars. What I would say is that there are adult CVNet also done, but I will answer these questions after I get the cost, because this also depends on country to country variation. So I will try to answer this in 3 or 4 country scenario. So I think with this, we have tried to answer many of the questions. Over to Dr. Bala, and you can reach my mail ID. I have given my ID phone number for any questions you have.
Thank you, Dr. Varun, for answering almost all the questions which our respective healthcare professionals have raised from the different parts of the globe. I think if still we would request if they have still any queries or questions, they can put it up to us, and we will get back to you on mail, and we will reply back to you. There is one query which is coming up, is that whether we will get the presentations or not. Yes, all of you are going to get the presentations once this webinar series would be over on 18th. So 19th you will get the mail from us, and all the presentation would be there with all of you in a form of PDF. Now, before I should close the session, I would say thank you to all the colleagues, those who have joined today. Thanks to Dr. Varun Arora. Thanks to RIS and GDC Ambassador Amar Sinha sir, our Director General of RIS, Professor Sachin Chaturvedi, our colleagues from RIS, Mr. Arora, Mr. Abhinav, and all my PHFI colleagues, leadership of PHFI, Professor K. Srinath Reddy, and all our team members, those who have worked hard to make this particular thing possible today, because we were planning this thing since last 10 days. And then last but not the least, I would want to say big thanks to our faculty, Dr. Sanjay Kalra, because he was the one major pillar at the back who has helped us to connect with all of you in different parts of the globe. And with his help, we got around 350 registrations from 22 countries. And that has happened only because of his help and his support. So thanks to him also. Over to Ambassador Amar Sinha sir, if you want to say any closing remarks, sir. Over to you, sir.
No, I just want to thank all of you. It was very interesting, and I'm sure I'd like to listen in to the next 3 days also to the experts.
Great, sir.
And special congratulations to you and the speaker, who is absolutely outstanding.
Thank you, sir. Thank you, sir. Thank you. Thank you. So at the same time, tomorrow at the same time, we will join 3 o'clock for the next session. All the best. Happy learning. Stay safe. Stay home. Bye.